It is challenging as yesterday because we have imatinib since 20 years. It's a safe drug, is a drug with a high level of efficacy and is safe in the long term either. And more is generic in most part of the world, so it's much less expensive than second generation TKIs, which are in turn more tough. They are clearly more active in treating CML, I meaning nilotinib, dasatinib, and bosutinib, and more ponatinib, which is a very strong third-line agent. Second generation TKI are more expensive, I said, but are clearly in randomized clinical trial more effective, particularly in determining early responses. I must say that in the long term, the overall survival, which is a very important endpoint, is the same if we start imatinib or second generation TKI. Two large clinical trials confirmed, but clinical trials are not all that count, and we need to look inside to other variables to decide in which situation today imatinib is a good choice, or in turn second generation are a good choice as first-line treatment. Then what is important is really highly important to follow the guidelines or recommendation to proper monitor the patient, because if you decide to start imatinib first, for example, and you follow the recommendation, then you can change eventually to a second generation TKI, not too late, not too early, but simply on time. And we can do that.